So we are back again after this short coffee break, and I have to say sorry for that because we were a bit late on the program. Now we move to the next session. It is about advanced chambers evaluation, and our first speaker, Professor Christova, will talk about how to evaluate left and right ventricle with 3D cardiography. Professor Christova?
Yes, just a minute to find my slides.
Yes, of course.
And now to share. Okay, you can see this is my presentation. Thank you once again, Kostas, for the good introduction. I would like to share some of my opinion about the 3D echocardiography for the analyzing the left and right ventricle function and advancing quantification, because this is the big topic, and I will show some of the talks that it's possible to introduce. Actually, the three-dimensional echocardiography has a very long history, around 5 decades. The first imaging that we could introduce from the 2D echo and the 3D guided echo machine that is possible to introduce is around the 16 decades of the last years, but the three-dimensional echocardiography that we know from the nowadays, it's coming from the 1990 actually, which is possible to look at these images. So the real-time 3D echocardiography actually has the history from the 2000, and there is some of the possibility that we could quantificate the function of the ventricles novel ways. So the quantification is more limited by the 2D echocardiography because we have the foreshortening geometric assumption, which is not possible to have in the 3D. So how to quantify the left ventricle function? One of the possibility to use the ultrasound machine to make directly analysis, and another possibility is to use another workstation. We're loading the 3D echo and with an auto initialization of the static surface. Then we could perform this 4D speckle tracking with the dynamic surface model, and to analyze these 3D 4D parameters like the volumes, ejection fraction, strain, twist, and displacement, which is very useful when we have a few minutes to analyze the whole left ventricle on the machine. So the 4D analysis of the left ventricle, it's possible to have in only from one cycle the ejection fraction and diastolic volume and systolic volume, stroke volume, and regional volume analysis, which one it's possible to use for the assessment of the left ventricle desynchrony, 3D strain, left ventricle twist and torsion. Actually, this is the guidelines and standards that recommended to use for the nowadays for the usual daily practice, the three-dimensional echocardiography. As conclusion from these guidelines, we could use the three-dimensional echocardiography for assessment, the left ventricle ejection fraction, as recommended over the use the 2D for to provide more accurate and reproducible measurements. Actually, the global three-dimensional left ventricle function is possible for assessment in very simple and fast way, less than 10 seconds, more accurate than the two-dimensional echocardiography. The data is very comparable to data from the MRI, and it's really ready for the routine use in the daily clinical practice. Actually, anti-regional 3D left ventricle function assessment is useful for selected cases for assessment of the synchrony of the ventricle and the 3D stress echocardiography. There is also the great future potential from this guideline, like to analyze the left ventricle shape analysis. We can use for the analysis the fluid mechanics also, and to analyze the three-dimensional strain. This is one of the first studies that compared the 2D and the 3D images with the MRI data from the left ventricle mass volumes, why the 3D echo is more accurate, because we can find the true apex, we can have assumption the foreshortening and error of that is coming for the foreshortening for the 2D, and we could analyzing actually the segmental dilatation, which is not very useful on the two-dimensional echocardiography. Data was correlated with the MRI for the end-diastolic and end-systolic volume, and the correlation coefficient is very high. There is several studies from the last years, and excellent correlation, but the 3D three-dimensional echocardiography underestimates some of the volumes. There is also good correlation from this study, which is shown later from the 3D and 2D echocardiography volumes and by CMR. Also, three-dimensional speckle tracking, this is one of the possibilities from some of the vendors that we have now on our everyday practice to analyze the speckle tracking from the three-dimensional echocardiography. This is very useful because it's possible to make very automatically. And the three-dimensional strain, we have one new parameter that is very convenient to use on the from the practical part, but this is the array of strain, which is combination from the longitudinal and circumferential strain in one moment. The three-dimensional strain also is correlated very good for the ejection fraction, for the cardiac volume output from the global circumferential strain. Radial strain, it's also correlated very good way that we have. This is the inter-observer analysis published in JACE in 2012. So inter-observer variability, it's very low for the global longitudinal strain. The other data we could correlate from the using the three-dimensional echocardiography that could be very interesting when they're analyzing the twist and the untwist data. The 3D echocardiography could give more accurate data regarding the distance when we measure of the 3D, and the parallel planes is very easy to define for the twisting and untwisting also in one moment when we analyzing these parameters. 3D echocardiography also is possible to analyze in the stress echocardiography for the our patients. The time which is required for the image acquisition, it's very short. Operator depending image acquisition, we can use also full volume 3D, which is to collect the 4 heart cycles and to have every these images that we needed for the analyzing the people, or some of the people from the 2-dimensional stress echocardiography. It's difficult to represent much segment during the stress, but did not encompass the entire left ventricle, which is missing for the wall motion stress abnormalities. There is another study which is published in 2010 from a group of the Professor Bandano. He is using the results from the deep epidermal stress echocardiography from the baseline and during the peak. And there is a very good correlation about the results that we could analyze from the baseline on the peak of the stress of the two interdimensional echo during the stress. There is many limitation also but the good that technique is improved nowadays, and we could have the good quality of imaging and to reduce the cost and the effectiveness of this analyzing when we use it of the our practice. So the quick from the quick acquisition of the 3D for the all views, the full volume assessment. Also, and not for shortening for the 3D this is the better when we using the three-dimensional echocardiography for the stress echo in the clinical practice. The future for the 3D when we also use it in the nowadays, this is the combined hybrid fusion imaging, which is also possible to have in the sum of the machine now. This is the combination from the CT and 3D echocardiography and 2D echocardiography also, and to have images that correlated with the coronary artery generated with the CT. We can look at about the left ventricle area for the latest the contraction, and to have this 3D volume of the left ventricle, which is generated from the echo. This is the one of the our possibilities. Regarding to the right ventricle, the things are a little bit going further, because you can know that right ventricle geometry is a little bit difficult compared with the left ventricle, but the images of the right heart, it's possible to do also. This is the 2D images, which is a little bit limited from the 2D echo acquisition, but when we have time to difficult to estimate the right ventricle volume, because this is the very crescenting shape of the right ventricle. There is the additional separation between the right ventricle inflow and outflow tract. There is no uniform geometric consumption for the measurement of volume. There is also difficulties with this delineation of endocardial border owing to the well-developed trabeculation of the ventricle. Also, the difficulties with just adequate of the image acquisition for these people. Another limitation is difficult to standardize the evaluation of the method of the right ventricle function. There is many variation of the directional or location of RV of the common. There is also easily affected by the preload, afterload, or the left ventricle function. There is different complex contraction relaxation mechanism among the segments of the right ventricle. We cannot image the entire right ventricle only in one single view. But why we should do measurements of the right ventricle function? Because there is right ventricle is not only the conduit of the blood flow. There is a very unique function. We could have some prognostic significance in various clinical settings. We could analyze the risk stratification or guide the optimal therapy. The other maintenance, this is the adequate pulmonary arterial perfusion pressure, which is improve the gas exchange in the people. We have the mental low systemic venous pressure to prevent congestion of the tissue or the organs. Also to affect the left ventricle function, this is the limit of the left ventricle preload in some of the conditions with the right ventricle dysfunction. There is also ventricular interdependency. And right ventricle has prognostic significance in various clinical settings. The prognosis of the sum of the disease, which is like the patient with the chronic heart failure and the coronary artery disease, could we measure the right ventricle ejection fraction as an indicator from the increasing mortality this group. Right ventricle function also could predict exercise capacity in survival from the advanced heart failure. This is the study from Professor Di Salvo. Also, the right ventricle function is very crucial determinant in the short-term prognosis in several chronic heart failure. So the right ventricle imaging of the right heart for the 3D, we could have the entire right ventricle with a complex crescendo shape, separate the inflow and outflow track, completely visualized from any single two-dimensional view. We could find here the tricuspid valve and right atrium. So the assessment of the heart is actually starting for the actual 3D acquisition, which is easily repeatable. There is no geometric assumption. The data was validated from CMR. We could dynamically reconstruct the 3D images from the beating heart. There is also rapid spatial appreciation for the multiple representative perspectives and provide the all volume, stroke volume of the right ventricle, and also we could analyze the ejection fraction. The validation of this data was regarding to the data from the cardiac magnetic resonance data. There is some of the study which is looking about the semi-automated right ventricle analysis of the 3D software for the automatically validated assessment of the right ventricle volumes. There's very high and excellent correlation with two techniques with good inter and inter-observer variability, less than 30% for this in this study. This is the data from the group of the Professor Badano that they make the prospective study from the differences between the right ventricle volumes assessed by three-dimensional echocardiography and cardiac MRI. They look at about from the end diastolic and systolic volume, also and the ejection fraction. Right ventricle normative value for the home healthy volunteers. There is differences from the difference group of the like for the woman and for the women, the different ages, and also we could analyze the end diastolic and end systolic volume index, which is the better parameter when we have correlated with the body surface area. Value are shown from the mean and data and separate the standard deviation separately from the men and from the woman. 3D echo and data from this study, it's very well correlated for the MRI from the derived access for the right ventricle volume. There is good correlation and comparison between the predicted value for the obtained by the uplink for the our study population for the normative evaluated derived three-dimensional echocardiography and those obtained from the same population by uplink normative evacuation by CABIT and other autos. So the 3D echocardiography could open a completely new way to look at the right heart. If you want something in your life, you never had to, you have to something to do, you never done. So as conclusion, the right ventricle function is very important parameter in the cardiac disease. Two-dimensional is a relatively feasible method for assess the right ventricle dysfunction in clinical practice, but there is several new echocardiography techniques like the TDI, speckle tracking imaging, and three-dimensional echocardiography could give us the future information for the assessing the right ventricle function. Three-dimensional echocardiography could give us directly evaluation of cardiac chamber volumes without the need for the geometric modeling and without the detrimental effects of the foreshortening views of the ventricles. Directly 3D assessment of the regional wall motion analysis, we could quantificate the systolic asynchrony for the guided CRT in the left ventricle, 3D color Doppler imaging with volumetric quantification of the regurgitant lesions, shunts, and the cardiac output. This is the last my slides. Thank you for the attention. I think that I could conclude my presentation.
Thank you, Professor Christova. You managed in 15 minutes to give an overall perspective of 3D for left and right ventricle, and we appreciate that. I can see that we don't have any questions from the audience. I just want to make a comment that the advantage of 3D is that the inter-observer variability is very low.
Yes.
From in contrast to 2D, and we can be precise. We can measure ejection fraction, and I guess that in the near future everything will change if we include 3D ejection fraction for left ventricle in the management of cardiac pathologies of, for example, valvular heart diseases, or ischemic cardiomyopathy for CRT candidates. All studies that we know so far depend on 2D ejection fraction. But of course, we need large studies with many patients to conclude if we can rely on 3D ejection fraction for changing the indications for management.
I think it's we can mention that 3D is very useful when we look at about and follow up the patient for the in the oncology after the chemotherapy. This is the more important because it's reproducible from the ejection fraction especially.
Okay, so if you want to introduce the next speaker.
We can continue in our program. It's my pleasure to introduce the next speaker. This is Professor Picano from Italy. He will speak about the clinical application of the stress echocardiography in nowadays. Professor Picano is one of the experts of the stress echocardiography. He is one of the authors of the last guideline, which is provided from the European Society of Echocardiography. Professor Picano.
Good morning, ladies and gentlemen. Thank you, Casimira. Thank you, Professor Papadopoulos, for the kind invitation. It is a privilege and an honor for me to attend this important meeting and to share our experience on clinical applications of stress echocardiography in 2001. The stress testing with echocardiography is especially important in the current climate because there are unquestioned, undisputed advantages of stress echocardiography compared to competing techniques, since the method is patient-friendly, being free of ionizing radiation, and the contagion risk can be minimized with the use of drugs compared to exercise. Payer-friendly with affordable low cost, and we are aware that in times of healthcare rationing, small individual ways multiplied by billions of examinations become an unsustainable societal cost. It's physician-friendly since it is run by cardiologists living an imaging experience and not by radiologists living a cardiology experience. This puts the cardiologist echocardiographer in an ideal position to take the best of the advantage of the staggering versatility of stress echocardiography. And what is becoming more and more important, the technique is planet-friendly with low carbon emission and very little impact on climate. Stress echo is now considered the first line technique according to the latest recommendation of the European Society of Cardiology for patients with chronic coronary syndrome and more for applications in non-ischemic heart disease, which is the single item with the greatest increase in utilization rate according to recent statistics. And nevertheless, and in spite of these established advantages, 2021 was also the year of a new beginning for all cardiology and cardiac imaging in particular, stemming from a free important aspects that are related to sustainability of what we do, to the clinical meaning of what we find, and on the way we perform stress echo every day in clinical practice. First of all, we learned with the dramatic fall of 50% of acute hospital admissions for acute coronary syndrome, atrial fibrillations, and acute heart failure, attributed to the fear of contagion, but most likely, at least in part, due to fall in air pollution. We learned that climate impacts on heart and what we do in cardiac imaging lab impacts on environment. And now it is the time to ask us what is the impact in terms of climate worsening, carbon dioxide equivalent production, and in one word, environmental sustainability of what we do. And the environmental burden of an echo cardiac study is 1/10 to 1/5 of a CT study, 20 times and more less than a SPECT study, and 100 times and more less than a magnetic resonance study. Why this should be important? Because it is important in all aspects of economic and societal life. When we buy a car or when we travel, it is important what is the environmental impact of what we do. This should be especially important for cardiologists, since the climate change worsens air pollution worsens climate change, and both acutely and chronically affect cardiovascular health. It is time now for a green heart imaging new deal, and we have to know, to be aware, and to minimize the acts that we perform in the cardiac imaging lab. It is also important, and our generation witnessed this change over the decades. It is important that every medical act, and especially every act in the field of cardiac imaging, is measured not only with the benefit or diagnostic value coordinate, but also as a cost benefit. But the cost must include not only direct cost, but also downstream long-term costs, such as the additional cost of one additional cancer, or the environmental cost of climate changes and increase in air pollution. Risk benefit, which should include not only the acute risk, for instance, of stress testing, or subacute risk, for instance, of nephrotoxicity of iodine contrast used in CT or in coronary angio, but also the planet risk, the echo impact. There are 4 partners, and all of them are stakeholders when we decide what to do in cardiac imaging lab. The 4 partners are the physician, the payer, the patient, and the planet. Then there was in 2020 the year of ischemia trial, showing some data that are against conventional wisdom, that we have large ischemia, we should revascularize the patient to optimize the survival benefit. What we see in this trial is that the reductionistic approach does not pay off. We cannot consider the complexity of risk stratification and therapeutic approach to the patient only with one segment, in this case, coronary stenosis or inducible ischemia. There is much more than that on our heart than is dreamt of in a coronary angiography or in a CT or in a stress echo, based on regional wall motion. And now we move from stenosis vulnerability to patient vulnerability, and 5 variables and even more are now put together conceptually, methodologically, and logistically in the stress echo lab. The 5 variables are the 5 items of the ABCDE protocol. A for a synergy, focusing on ischemic or non-ischemic heart and epicardial coronary artery stenosis. Wet or dry lung with a B step, which stands for B lines and measures pulmonary congestion and extravascular lung water, weak or strong heart with the volumetric echocardiography measuring preload and contractile reserve, and weak or strong heart focused on the myocardium, the cold or warm heart, because if you have a preserved coronary flow reserve, your flow increases, your local temperature also increases, since myocardium is an erectile organ increasing flow and function and temperature with increasing flow, and in this way you focus on the very important coronary microvascular function when there is no epicardial coronary artery stenosis, with the D step for Doppler-based coronary flow velocity reserve. And the last, but not the least, non-imaging parameter at the end, we had a 100% feasible and 100% reproducible with 0 intra and inter-observer variability parameter in the echo lab, which is the heart rate, because the capability to increase the heart rate during exercise or adenosine or dipyridamole or dobutamine is an index of the cardiac sympathetic reserve to evaluate the slow heart, which does not increase during stress, and separate it from the healthy, fast heart, which does increase heart rate during stress. And one by one, in the last 5 years, A, B, C, D, E steps were added to the core stress echo protocol to achieve the elusive goal of the assessment of the patient vulnerability much above and beyond coronary artery stenosis. And we were lucky enough to put together an extraordinary team of people from all over the world in Stress Echo 2020, and the paper was published on JACC at the end of 2019, and we had the privilege to have a commentary from the editor-in-chief of JACC, Valentin Fusse, and he sees a future in which the use of the quadruple protocol with the assessment of coronary flow reserve with an extremely feasible technology can provide a lot of information back to the future of cardiology, not only of stress echo. And last year we published the paper also on behalf of Stress Echo 2020, and this time on the B step, B lines on thousands of patients, showing the diagnostic and prognostic value of this index. And again, there was an important editorial by Sharon Molvag, and clearly stating right from the title that stress lung ultrasound were making a splash and changing the face of the diagnosis and possibly treatment, because the pulmonary congestion phenotype can be the target of tailor-made intervention, and not only in coronary artery disease, but also in heart failure, valvular heart disease, hypertrophic cardiomyopathy. And as the tide of lung water rises, we are now ready vigilant with a probe in our hand. All these parameters, each and every one of these parameters can be titrated with different grades of severity. And this is true for A and the Synergy. We know this since 40 years, that the peak wall motion score index stratifies the severity of prognosis much better than simple presence or absence of inducible regional wall motion. But this is also true for coronary flow reserve, for B lines, for contractile reserve, and even for the least obvious of all these parameters, which is heart rate, in this case during dipyridamole stress echo, because dipyridamole is not only a coronary vasodilator, but like adenosine, it is a sympathetic, mild but clear sympatho-excitatory stimulus, which is not related either to blood pressure or to myocardial ischemia, and on the basis of the amount of increase of heart rate during any stress, you can identify different strata of prognosis and obviously orient specific therapeutic interventions in these patients, as we see in this paper from, again, a multi-center trial study published on the American Journal of Cardiology in 2019 on the STEP E. This is the conceptual and methodological platform to move from the one-fits-all, monocratic, monotheistic, monolithic view of stress ego as regional emotional abnormalities to personalized medicine. We have a paradigm shift from the conceptual viewpoint, from the reductionistic stress ego only based on regional emotional abnormality view to a comprehensive assessment of patient vulnerability. We move from the white light to a spectrum of different colors with a Newton prism, which is a stress ego, always very simple, always not time consuming. In 15 minutes, you can have assessment of coronary artery stenosis, alveolar capillary barrier, myocardial reserve, coronary microcirculation, cardiac autonomic dysfunction, and you separate the different phenotypes, the different risk strata. On one side of the spectrum, the ischemic, wet, weak, cold, slow heart. On the other side, low risk, very low risk, non-ischemic, dry, strong, warm, and fast heart. And this was also the reason for us to start a new venture, Stress Ego 2020. We have now new targets and always sharing the idea that multi-center trial can be a unique source of evidence and allow to combine in a rainbow coalition different talents, different experiences, different cultures. And this was the story of our research in the last 40 years, and is now the future of Stress Ego 2030. When we have around the clock 12 projects from post-COVID patients to patients stress ego in brain dead potential heart donors to solve the heart donors shortage, and up to coronary vasospasm. The privilege was to coordinate the awful lot of smart people that are present in far reaches of the globe, from Brazil to Argentina, from Siberia to Bulgaria, from Hungary to USA. And this spirit that was a part of the foundation of Stress Ego 2020 is now been transmitted in Stress Ego 2030. And with the help and the co-chair of Mayo Clinic Professor Patricia Pellica and all the friends from the four corners of the world. And the logo is still the Pisan Cantos under white clouds, Cielo di Pisa. From all this beauty, something must come out. Thank you for your attention. Good morning, I'm Eugenio Picano, present from Pisa, and first of all, let me thank Professor Casimira and Professor Papadopoulos for the very kind invitation. It is an honor to be here and to take at least virtually part to the debate, and I was really impressed by the quality of the presentations, and this is an opportunity because I learned a lot from Casimira and other people's presentation today. Thank you. And ready to address
the honor is ours, and we need to thank you for attending and giving the opportunity for all these participants to make questions to you, because I consider you as the father of stress echocardiography. We all learned from your books, and me personally.
There is two questions to Professor Picano. One is the view of using the speckle tracking of the contrast of the myocardial perfusion assessment in daily practice and the stress echo lab.
This is a very interesting study of potential clinical interest. At present, the community of Stress Ego 2020, now moved to Stress Ego 2030, decided to endorse a simpler approach based with some limitation, which is the Doppler-based assessment of coronary flow in left anterior descending artery, which is a proxy of the overall flow, but serves us very well to assess the coronary microvascular function, which is important prognostically, not only in coronary artery disease, but also in heart failure, hypertrophic cardiomyopathy, and other conditions, because this is so much simpler. And there are also data from Tom Porter and Nicola Gaibazzi. They assessed head-to-head the prognostic value of coronary flow velocity reserve, which has the big limitation that only addresses left anterior descending artery, and coronary perfusion and myocardial perfusion, which is an assessment of all regions. And at the end, the prognostic value was comparable for the two techniques. So for a
13 hours
simplicity, we went as a multi-center trial on Doppler assessment of left anterior descending coronary flow. Speckle tracking is very interesting for global assessment of regional function. Now we are evaluating, I think that it can be extremely interesting in some subsets, which are, as we know since 40 years, Petros did this study in the 80s, and we also did with different stress, that there are some forms of myocardial ischemia that are echocardiographically silent, without wall motion abnormalities. But with the new technologies, we learned that this does not necessarily mean that they are echocardiographically silent if we use new technology indices, such as subendocardial function with Speckle tracking and other indices. We learned that some forms of ischemia can be so limited to so strictly confined to the subendocardium that we can actually see some signs with new technologies. And this is the best, most important domain of applications of new technology, in my opinion. But we need more robust technology and more robust data to transfer this data to the clinical domain, in my opinion, at this moment.
Yeah.
Krasimira, these two questions from the audience are, I guess, the same about HOCM, obstructive cardiomyopathy hypertrophic. Either if we don't have exercise echocardiography, if we can use the butamine, and which gradient do we use for evaluation of these patients?
This is very important. Again, there were the latest guidelines of the American Heart Association on hypertrophic cardiomyopathy that basically endorse and accept only the evaluation of dynamic gradients during exercise in guidelines, because of this they are useful to identify the obstructive phenotype, and this can have important therapeutic correlates. But in my opinion, this history, this chapter of the functional testing in hypertrophic cardiomyopathy will be completely rewritten in the next 5 years, because we have learned, but others have found, that there are a lot of important phenotypes that should be assessed. First of all, in guidelines, it's clearly written that what you see with dobutamine is not related to what you see with exercise, and so it is formally discouraged to use the pharmacological stress echo. And this is important, and it is true. But there are many other things that are present in the big heart of hypertrophic cardiomyopathy that we should look for. For instance, first of all, there is ischemia, because coronary artery disease is frequently associated with hypertrophic cardiomyopathy, and regional wall motion can be induced with whatever stress, and it is important because it has a prognostic meaning even in the absence of coronary artery disease, because hypertrophic cardiomyopathy can have ischemic vulnerability independently of coronary artery stenosis. Then there is very important the pulmonary congestion phenotype that you can assess with B lines. And you can have B lines independently of all the other variables. You can have an excess contractility and a depressed contractility in the various stages. And this is especially important. And now you can identify it not so much with ejection fraction, but with force assessment, which is load independent. You have a microvascular disease, which you can assess with myocardial perfusion in presence of normal coronary arteries, can be impaired, or with left anterior descending artery coronary flow imaging. And you can have even extremely important chronotropic incompetence that you can assess during physical or pharmacological testing, including dobutamine, including dipyridamole or adenosine. And if you have a limited increase in heart rate, you have chronotropic incompetence phenotype. With stress, you can assess also important step F functional mitral regurgitation. You can assess step G, the gradients. Each of these is extremely important, and this chapter has to be written from scratch because hypertrophic cardiomyopathy is not gradient. And probably gradient, when you go to assess the prognostic value, is the least important of all these parameters. You can get them in a one-stop shop with stress echocardiography. And obviously, each phenotype has a therapeutic correlate. For instance, diuretics are formally contraindicated, but if you have a pulmonary congestion, they will benefit from B-lines driven diuretic therapy and so on. If you have a coronary microvascular dysfunction, this is a selective target, nothing to do with gradients, but only gradients are in guidelines, and rightly so, because this is the existing evidence. But now, for the echocardiographic community, there is the big scenario, the possibility to build evidences on this personalized approach to hypertrophic cardiomyopathy.
About B-lines, do you include it to your diastolic stress echo protocol or in ischemia detecting as well?
No, very good. No, B-lines are, this is one of the big sub-projects of Stress Echo 2030. And yes, of course, because we are very unhappy now with the way that in Stress Echo lab, but in cardiology, the heart failure will reduce with preserved ejection fraction is diagnosed. There are two main concepts that we should be familiar with. First, stress echo functional testing is important to screen out patients that have extra diastolic causes of heart failure and preserved ejection fraction and have nothing to do with diastole. If you make a first stress echo, you see inducible ischemia, and dyspnea can be an angina equivalent in patients with increased cardiac natriuretic peptides. You exclude the severe mitral regurgitation, which is a totally different issue. You exclude intraventricular gradients, which may develop in patients with hypertension, hypertrophy, independently of hypertrophic cardiomyopathy, as our friend Carlos Cotrim and others have shown over the years. And then fourth, you see chronotropic incompetence. So you screen out these patients. Then you have patients with suspected diastolic dysfunction, and you apply B-lines, you apply all the protocol, but especially B-lines because they are a direct sign of acute backward heart failure. And if they are for dyspnea, what regional wall motion dysfunction is for ischemia, a direct positive imaging proof that water is accumulating, likely due to increased wedge pressure during exercise or during pharmacological stress, because both dobutamine and adenosine, dipyridamole, are potent diastolic stressors. First of all, dobutamine because it decreases the heart rate, so the diastolic filling time, and adenosine, dipyridamole, because they have a direct effect on diastolic phase. As a matter of fact, with exercise, which is the perfect test when they can exercise, or with pharmacological test, very often when you have heart rate with the preserved ejection fraction, you have B-lines that are direct index of acute backward heart failure. So the brief answer is yes, very useful. We are studying it intensively.
Okay, we have many questions from the audience. I'm not sure that we have the time to answer all of these. Perhaps we can help a colleague that has a young male with coronary fistula, and he performed an exercise echo with ergometric bicycle. He found new regional wall motion abnormalities and ST depression, and he discussed with the interventionist to to have it managed. If you agree with this approach?
Yes, it's well described that with exercise, and even it's been described with vasodilators, because you basically induce a still phenomenon between coronaries with vasodilation associated with exercise. And so it's well documented in the literature that you have ischemia, even in presence of normal coronary arteries, when you have this anatomical abnormality. And then in some cases, it has been documented that the correction of the fistula leads to normalization of stress testing. There are solid physiological basis on this, and there are some, in the literature, also in the recent guidelines by the American College of Cardiology, this is coronary abnormalities are a class 1 indication to stress echo functional testing. So in the 2019 guidelines of the American College of Cardiology Foundation, American Heart Association.
Okay, thank you very much.
Thank you to you. It has been a pleasure. Now, if you don't mind, I will stay to learn from next lecturers. Thank you very much.
Next lecturer is also a stress echo expert. Professor Nichogiannopoulos.
Thank you. Bye-bye.
Thank you, Professor.
Bye, Eugenio.
Ciao, Vedros. Your background is imperial style.
Absolutely.
Ciao.
I'm honored also to introduce Professor Nichogiannopoulos from London and Greece. He's also top expert in stress echocardiography, but at the moment he will discuss about echocardiography in cardiac amyloidosis. Professor, thank you for joining this echo meeting.
It is my pleasure, and Kostas and Christina, thank you for putting together such an important meeting in the southeast of Europe. So we are changing tack now, and we will talk about amyloidosis and how echocardiography can help out. Obviously, cardiac amyloidosis is the hallmark of this cardiomyopathy called
we lost connection with Professor.
On the one side versus the non-familiar on the other side, which are generally called as phencopies.
Professor, if I may interrupt, can you please share your screen again, because yes, we lost connection. If you can share your screen again.
Oh, okay. 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 Can you see it now?
Yes, and if you can go to full screen.
All right. Okay, shall we continue?
Yes.
Can you see it?
We can see your slides.
So because we've talked a lot about hypertrophic
we can see the slides, but not full screen of the presentation.
What did you say, Kostas?
Now we are okay, Professor. You can proceed.
I am in full.
Yes, we can see it in full screen now.
Maybe a time delay.
Yeah.
So because we are going to talk a lot about hypertrophic cardiomyopathy, you know that the histology, it is greatly different between the disarray of myocardial filaments in patients with hypertrophic cardiomyopathy, whereas in amyloid heart, there is no disarray. And importantly, there is no hypertrophic thickness with normal nucleus to periphery of the cell distance. But what makes the wall thick is the interposition of the amyloid protein in between the cardiac muscle fibers. So in a way, it is when you build a wall.
Professor, we face some problems with your connection, perhaps.
So what did we lose now?
Again, the presentation. Perhaps the connection is unstable, or
okay. I'm on with a wire connection, so it should be okay. So what about now?
Let's try again. Yeah.
Are we up and running?
Okay. We can see your full screen.
So yeah. I continue with, okay. So obviously amyloid heart disease is not a new discovery. It has been going on for decades. But what has changed in very recent years is that we have recognized now the amyloid heart disease as a cause of heart. We have recognized patients with low gradient severe aortic stenosis who may have amyloid deposition in the myocardium. And this is the cause of low gradient severe aortic stenosis. We have now new diagnostic methods in imaging, both on echo, MRI, and nuclear. So we have now redefined the definition of amyloid and subgroups. We have, importantly, new treatments that may be different in different parts of amyloid, different types of amyloid deposition. So from an untreatable disease in the past 20 years, today the disease is treatable. That makes the need for accurate diagnosis and subclassification of the diagnosis of amyloid heart disease even more important. Now, coming to the treatment, there are two different treatment strategies in the two forms of amyloid. In AL amyloid, on the left, you have, we have autologous stem cell transplantation. We have expensive drugs like bortezomib and combination of steroids, of dexamethasone. Whereas in patients with the transthyretin cardiomyopathy, we have predominantly signs of heart failure, liver transplantation, and new drugs like tafamidis, which is a TTR stabilizer, and the other drugs that you can see on I don't know why we keep losing. Okay, so I think we can continue. What is certain in the different treatment methods that beta blockers, angiotensin converting enzyme inhibitors, or angiotensin II receptor antagonists are not effective in patients with amyloid heart disease. So we need to be very careful with diuretics because of the restrictive feeling, and the digoxin and calcium channel blockers are contraindicated. So that makes the need for accurate diagnosis of amyloid heart disease very, very important. But what you give to some patients with heart failure, you should not give if the heart failure etiology is amyloidosis. Now, the two types of amyloid heart disease, you know them. It is transthyretin protein with a 2 subtype wild form and the hereditary form. The transthyretin protein today is by far the commonest. There are many mutations in the hereditary that may be in different parts of the world. There is predominantly a sense of motoric polyneuropathy that can be a hint to make a clinical diagnosis. There are considerable variations in cardiac involvement, and there is a variable rate of progression. Not all are progressing in the same rate. And survival is in years. Importantly, in transthyretin amyloidosis, there is more ventricular hypertrophy, or better, ventricular wall thickness. In contrast with the AL amyloidosis, which has less hypertrophy or less wall thickness, but more ventricular dysfunction. So these are two major differences between AL and TTR amyloidosis. So TTR, more hypertrophy, less dysfunction. In AL amyloidosis, less hypertrophy, more dysfunction. Remember that, it's very, very important. So it is recognized more and more patients with wild type transthyretin amyloidosis because we live longer. The age population has increased, the average population has increased, therefore, in a way of a degenerative disease, and the more patients live longer, more patients will develop wild type amyloidosis. So transthyretin amyloidosis. So this is why we encounter that now even more frequently. In a way, cardiac amyloidosis is a zebra hiding in plain sight. This is because the phenotypes of cardiac amyloidosis are concealed and often unrecognized behind other conditions, such as hypertrophic cardiomyopathy, such as aortic stenosis, or even hypertensive remodeling that can mimic patients with cardiac amyloidosis. So a zebra hiding in plain sight. We can misdiagnose cardiomyopathy, we can misdiagnose aortic stenosis with low gradient and hypertensive heart remodeling, but the underlying condition is cardiac amyloidosis. Now, therefore, we have diagnostic challenges. Older patients now we face, more than 80 years of age, 20% of those who have heart failure with preserved ejection fraction may have wild type amyloidosis, TTR. Low flow, low gradient aortic stenosis. Look at the numbers. 20% of the over 65 may have amyloid. Hypertrophic, non-obstructive cardiac hypertrophic cardiomyopathy. About 5 to 10% may have amyloidosis. A very good clue is patients who have carpal tunnel syndrome. Careful to make the diagnosis. ATTR probably more frequent than AL amyloidosis, and lumbar spinal stenosis or ligamentum flavum. These patients may have wild type transthyretin amyloidosis. Now, I want to emphasize one thing. There is a lot of talk about this imaging modality is the gold standard versus the other. It's nonsense. There is no gold standard in medical imaging. No step, no medical test is 100% accurate. So whoever claims that my imaging modality is the gold standard versus the other imaging modality, I'm afraid they do not understand biology. So remember that. facts. The diagnosis of amyloid heart disease is often delayed until patients develop end-stage heart failure, and there is often a misdiagnosis. Low voltage ECG, despite increased wall fluid doses. ECG is very important. Look outside the box. Also useful serum and urine electrophoresis for light chain concentrations and the deformation imaging, as we will see, very, very important. However, if we are not talking about gold standards in imaging, there is one gold standard in diagnosing cardiac amyloidosis, and this is tissue biopsy is the gold standard. Congo red stain deposits can be identified by biopsy. So that can also determine the specific subtype and plan most appropriately and targeted therapy. Important clinical clues over and above imaging. It's if you have a patient who has high blood pressure and suddenly the blood pressure is normalized, then think of amyloid deposition, because there is production of heart failure, the systemic hypertension becomes normotensive, and you may need to stop the antihypertensive treatment. Think of amyloid. Patients who are intolerant on beta blockers, think of amyloid. History of heart failure with carpal tunnel syndrome, think of amyloid. Lumbar spinal stenosis and biceps tendon rupture, think of amyloid. Unexplained peripheral or autonomic neuropathy, think of amyloid. And left ventricular hypertrophy or increased wall thickness, but with low voltage ECG, think of amyloid is necessary. Biomarkers are very useful. Troponins and BNP are all very useful. ECG, CMR, the skeletal muscle scintigraphy, all these are very useful, but never 100% sensitive and 100% specific. We need endomyocardial biopsy. Red flags. So these are the 8 red flags for transthyretin cardiomyopathy. One is the reduction of longitudinal strain with apical.
Professor, once again, if you can share again the presentation.
Yes, I noticed, sorry, I'm not sure why this is happening, but.
No worries, this is a live Congress.
Bad weather.
Technical things can happen.
Yeah, okay, now?
Yes, do you want to proceed without? Yeah, perhaps you want to proceed without full presentation, just showing the slides like this. Whatever you like. Or,
I can show that.
Okay.
How, can you see the full presentation now?
Yes.
Okay, so discrepancy between ECG and the increased wall thickness. Atrioventricular block. First degree AV block in the presence of increased ventricular wall thickness. Very, very important red flag. Echocardiographic hypertrophic phenotype with some associated infiltrative features, such as increased thickness of the atrioventricular valves, the mitral or tricuspid valve, interatrial septum, or right ventricular hypertrophy. On the other side, you have marked extracellular volume expansion by CMR, symptoms of polyneuropathy, very important to think about amyloidosis, history of bilateral carpal tunnel syndrome, and a mild increase in troponin levels on repetitive occasions. All these are red flags that raise the index of clinical suspicion of amyloid heart disease versus other forms of hypertrophy. So patient population deemed to be at risk for transthyretin cardiomyopathy, amyloid cardiomyopathy, is a patient with heart failure or one of the red flags we just mentioned, and increased wall thickness. So think of increased wall thickness more than 14 millimeters. What are the patient's symptoms? Heart failure, aortic stenosis, preserved ejection fraction. Is the patient a male patient more than 65 or female more than 70-year-old? These are patients deemed at risk for possible amyloid. This is a typical example of an ECG. You have a patient with a ventricular hypertrophy of about 15 to 16 millimeters. Yet, instead of expecting a voltage criteria for hypertrophy, you have this low voltage in the precordial leads. That is a hallmark of cardiac amyloidosis. Think laterally. There are different phenotypes. You have one phenotype on the left, a different phenotype on the right. The right is a classic hypertrophic cardiomyopathy. And in the bottom is heart failure with ATTR amyloidosis with some pericardial effusion. I'll come back to some of these examples. So there is ventricular hypertrophy, variable degree, and a restrictive physiology. Echocardiography, of course, is the first line investigation, perhaps after the ECG. Blood for immunoglobulins in serum or urine. Genetic testing for the hereditary form of ATTR, and scintigraphy with radio-labeled tracers or the SAP scan, which detects mostly the peripheral amyloid deposition, but does not visualize heart easily, and eventually cardiac biopsy to rule out or to confirm the diagnosis. The most common features with echocardiography is increased wall thickness, but remember, we cannot talk about hypertrophy. Cardium, the small but well, or even poorly contracting left ventricle, involvement of the right ventricle in the vast majority of patients with amyloid as opposed to hypertrophic cardiomyopathy, and enlarged left atrium indicating diastolic dysfunction, increased diastolic pressures. Valve regurgitation is usually mild, interatrial septal thickness, and pericardial effusion, which is generally a poor prognostic indicator. But all of these traditional echocardiographic features are of limited sensitivity. So don't be based on that. So this is a classic example of an advanced form of cardiac amyloidosis. You see the texture of the valves very similar to the texture of the myocardium in the four-chamber and the short axis. The ejection fraction here is probably normal or near. But look at the patient also. 48-year-old male with breathlessness. What do we see? We see systolic anterior motion of the mitral valve, concentric hypertrophy, dilated left atrium, and Doppler shows a high gradient. This patient was referred to us with diagnosis of hypertrophic cardiomyopathy. Wrong. This patient has a classic amyloid on biopsy. So in early cardiac amyloidosis with preserved ejection fraction and rather vigorous ventricular function, the patient can produce a gradient, but this is not hypertrophic cardiomyopathy. So careful, careful, and again careful. So this is an interesting, a very nice study from Germany, whereby from the reconnect. Sorry, we have to do that several times. Okay. So, okay, now that's an important study because it shows that in these patients with over 200 patients, half were with AL amyloid and the other between wild type and hereditary. And what you see here, without going in full detail of the slide, is that patients with AL amyloidosis had a less hypertrophy. The ventricular septal thickness was less than the TTR amyloidosis. The left ventricular mass was less, but there was more frequently pericardial effusion and more frequently heart failure as expressed from the NT-proBNP. So AL amyloidosis have less hypertrophy, more heart failure. So this is quite characteristic. And on the right, you can see this small differences between the hereditary and the wild type of amyloidosis. So major differences clearly stated by this quite extensive study. Yes, we have restrictive physiology. You know the classic echocardiographic findings of restrictive abnormal mitral inflow, atrial dilatation, pulmonary venous flow, isovolumic relaxation time, etc. I will not go too much in detail. This is the typical echo features of restrictive physiology, very low A wave or disappear A wave, and the dominant diastolic flow when you look at the pulmonary venous flow with a very short systolic forward flow from the four-chamber view. So these are quite characteristics. ENA wave is not very reliable because you see here in this example on top left you have a fairly normal transmitral velocities and deceleration time, yet on tissue Doppler you have an increased E to E prime ratio, both seen in the lateral wall but also in the septal wall. So that tells you that something is wrong with this the transformer. So don't trust very much. One thing is interesting and useful, however, is to differentiate the diagnosis of restrictive filling in early diastolic long axis myocardial velocity between constrictive pericarditis .
Professor, if you can share again the screen and proceed without full screen of the slides.
Yes.
If we can,
okay.
Because the connection is not very good.
Let's see that. I will do. Yes, I know how to correct it now, so I'm very quick.
Okay.
So you see in constrictive pericarditis, the E prime is very high, whereas in restrictive cardiomyopathy and amyloid patients, there is a clear distinction between the amyloid and constrictive pericarditis. So if there is any doubt, although there shouldn't be any doubt, then E prime can help the differential diagnosis. Prognosis, very important in these patients. When the deceleration time is less than 150 milliseconds, the prognosis of these patients is rather abysmal. And you can see in this curve that deceleration time less than 150 plus or minus E to A wave, there's not too much, but it is mostly the deceleration time less than 150. More than half of these patients died in this study. So very important to remember that, deceleration time. often patients with atrial fibrillation and restrictive cardiomyopathy of amyloid, we don't have it, we cannot assess the diastolic function very well. And myocardial flow propagation by Caloram mode can separate constriction on top here with a very abrupt slope versus the restrictive pattern, which is a very slow upslope. So that may be useful in, particularly in patients with atrial fibrillation. BNP also very important to separate constrictive pericarditis from restrictive cardiomyopathy. In constrictive pericarditis, the BNP levels are usually normal. So again, we can use other modalities, other factors to establish the diagnosis. Prognosis is worse when there is much increased wall thickness, more than 14 or 15 millimeters. I will share again my screen. I do that very quickly.
Would you like to conclude?
Here you have now, I'm coming to the end of my talk. I'm going to the end of my talk. I have to talk about longitudinal strain, of course, and the difference between the apical preserved strain values compared to the base and mid wall strains, and therefore there is a gradient. I will pass on very quickly. There is a gradient between base and apical strains, and from this slide you see that speckle tracking derived parameters are much more accurate in the diagnosis of cardiac amyloidosis compared to the more traditional, so to speak, echo parameters. So I lost a lot of my time on sharing the screen.
Yeah, no worries, Professor.
Sorry. But I have not long to go. So this is quite an important study showing the gradient between the low longitudinal peak systolic strain in the middle and basal part of the heart compared to the apex, which is preserved. And this is the left systolic apical to base ratio is higher in patients with amyloid versus other forms of ventricular hypertrophy. And in this study, they show that the ratio of 2.1 between base and apex can separate patients with other forms of ventricular hypertrophy. So that is a number that you probably can remember. And the two other parameters
Professor, what would you say if we just go through the slides without full presentation to conclude? Because the connection is is very difficult.
Yes, I can see that. Okay, and I will. So that's another important study that shows the relationship between ejection fraction and global longitudinal strain in patients with ventricular patients with hypertrophic cardiomyopathy, which is prelude for the next talk, versus red dots patients with cardiac amyloidosis. And you see that the ratio between GA with hypertrophic cardiomyopathy, so there is better ejection fraction in patients with hypertrophic cardiomyopathy, and lower longitudinal strain in patients with amyloid. And we'll talk a little bit about the rest of parameters. And this is just to demonstrate that the advanced echo parameters in red columns here, whether it is global longitudinal strain, circumferential strain, radial strain, the ejection fraction versus strain, relapse, and systolic apical basal ratio, all these parameters have a better diagnostic accuracy than the blue columns, which is the more traditional echo parameters such as ejection fraction, E2E prime, deceleration time, etc., etc., etc. So I will conclude, therefore, that patients with amyloidosis, it is an infiltrative disease. There is worse prognosis in AL amyloidosis than the transthyretin-related amyloidosis. The increased wall thickness, remember, which may be a hypertrophic cardiomyopathy phenocopy, may also involve the right ventricle. There is some characteristic echo descriptions as we discussed. Low voltage ECG, when it occurs, not always, it is quite characteristic. Reduced longitudinal strain in severely impaired at the base compared to the apex, which is preserved, and the longitudinal function. But remember, endomyocardial biopsy is, at the end of the day, if we want to talk about gold standard, is the only gold standard in the diagnosis and subtyping of these conditions. Thank you. And apologies for the internet connections.
Thank you very much, Professor, and sorry for the inconvenience you faced. You don't have to worry about anything. This was a very interesting topic. We had many comments, nice comments from the audience, because even with technical problems, we learned a lot about how to evaluate patients with cardiac amyloidosis. We have a lot of questions, but we don't have time. I've chosen just one question that if you can answer quickly. If we can use sacubitril valsartan in cardiac amyloidosis patients.
Yes, you can use it, but we have no data. So do a prospective study and see if these patients can improve, but we have no data.
Thank you very much. I apologize from the audience. We cannot proceed to further questions. And Professor Christova, if you can introduce the next speaker.
Thank you, the Professor Yiannopoulos, with very interesting presentation. We can continue with the next our speaker. It's my pleasure to introduce Professor Elena Kinova. She is the President-elect of Bulgarian Association for Cardiovascular Imaging. The topic of the Professor Kinova is very interesting. She has developed one clinical trial about the hypertrophic cardiomyopathy, and there is something new that we could introduce to our audience.
I'd like to express my high appreciation of the idea and the organization of this first Southeastern ECHO meeting. My topic is of hypertrophic cardiomyopathy, and this is important because hypertrophic cardiomyopathy has been considered as one of the leading causes of sudden cardiac death and also as a cause of progressive heart failure. It's a common genetic disease with the frequency in 1 in 500 people in the population. The characteristic sign is an increased end-diastolic wall thickness unexplained by abnormal wadding conditions. As we know, in 40 to 60% of the cases, there is a sarcomeric protein gene mutation. Now we know that the most of the patients are asymptomatic and have a normal life expectancy. In other percent of the cases, the rest of the cases, there are other reasons, some other genetic and non-genetic causes of hypertrophy, or in up to 30%, the reason is not known. Diagnostic criteria for hypertrophic cardiomyopathy is maximal wall thickness over 15 millimeter, and in asymmetric forms, the septum to posterior wall ratio should be over 1.3 in normotensive patients and over 1.5 in hypertensives. In first-degree relatives, the maximal wall thickness should be equal to and greater than 13 millimeters. There are several types of phenotypes classifications. The Marron's classifications is based on the segments with hypertrophy. Functional type classification in obstructive hypertrophic cardiomyopathy may be subaortic obstruction, mid-ventricular obstruction, or cavity obliteration. According to the septal morphology, we have 4 types of cardiomyopathy, with sigmoidal septum, with reverse curve septum, apical form, and neutral or almost flat septum. The probability of positive genetics tests is the highest in the form with the reverse curve septum. Probability is moderate in apical and neutral forms. And the sigmoid septal is a characteristic of elderly people, older patients, which have also hypertensive disease. There are abnormalities in the mitral valve apparatus. Mitral valve leaflets may be elongated, thickened, dysplastic, and prolapsing. Papillary muscles may be more than 2, and they may have apical attachments. The cords also is elongated and thickened, and this contributes to development of subaortic LV outflow tract obstruction. By MMOT, we can register a sum of the anterior mitral leaflet, which may be complete and severe or incomplete. With CV Doppler, we register LV outflow obstruction, which has late peaking spectrogram and shape of a dagger. Mitral regurgitation develops. The jet is eccentric and has a posterolateral direction. Recently, Ferrazzi et al. Published data about the muscular mitral aortic discontinuity in obstructive forms of hypertrophic cardiomyopathy. They found that there is a muscle band between aortic valve and anterior mitral leaflet, and when this band contracts, this leads to displacing of the anterior leaflet motion towards the LV apex. And this is the mechanism of LV outflow tract obstruction. This band, muscular band, is characteristic for younger patients and patients with sarcomeric mutations. In older patients, other congenital or acquired mechanisms may be the reason of LV outflow obstruction. This band elongates the anterior mitral leaflet, and we can measure it from a parasternal long axis view. The massive apical hypertrophic cardiomyopathy in a 22-year-old woman is presented. The woman has a congestive heart failure, ejection fraction is preserved, 54%, but the left ventricle is dilated almost 6 centimeters in diastole. Here we can see the dilated left atrium and mitral regurgitation. This patient has a restrictive mitral filling pattern and also reduced E' velocities of the mitral annulus, and also the duration of the difference between duration of AR and A wave is over 30 milliseconds. Here we have very high filling pressures. On the upper right panel, the fetal heart of her baby in the 7th lunar month is shown, and we may see that there is some thickening in the apex. Unfortunately, the baby dies 1 month after the birth. On the first panel, a patient with non-massive apical hypertrophic cardiomyopathy is presented. The strain, longitudinal strain in apical and mid-segment level is very reduced. On the second panel, there is a left ventricle with mid-cavity gradient and hypertrophed mid-level of the ventricle, segments of the ventricle. And in the third case, there is a large apical aneurysm in a woman with a history of a stroke. Apical aneurysm is not so common. The rate amongst 1,332 patients is 2.3%. But these patients have higher rate of mid-systolic obstruction and late gadolinium enhancement. And also, which is very important, they have higher risk of adverse cardiovascular events. According to American guidelines from the last year, ICD patient selection is very important, and in this guideline, 3 new major risk factors were included: apical aneurysm, ejection fraction below 50%, and extensive late gadolinium enhancement on CMA over 15%. Hypertrophic cardiomyopathy is a diastolic disease and a prototype of heart failure with preserved ejection fraction, diastolic heart failure. But the assessment of diastolic dysfunction is, in fact, very difficult. From 4 conventional parameters to grade diastolic dysfunction, the most reliable parameter for identifying higher filling pressures is the parameter of the difference of between duration of AR on pulmonary venous spectrogram and A mitral wave. This parameter is even in very difficult cases may identify patients with higher LV filling pressure. For grade 3 diastolic dysfunction, 3 criteria must be present: restrictive mitral filling pattern and reduced E' velocities of the mitral annulus. It's not enough to have these patients have a very high filling pressures if the patient has only restrictive mitral filling pattern. We have additional parameters in difficult cases: L wave, diastolic stress test, reduced left atrium strain, and early diastolic strain rate of the left ventricle. If the patient has severe mitral regurgitation, we can use only tricuspid regurgitation and the difference between AR and A. In this case, we assess LV diastolic function, and we graded the diastolic dysfunction as grade 1. Here we have only one parameter, increased indexed volume of the left ventricle, which is 43 milliliter per square meter in this patient. What about systolic function? Ejection fraction is supernormal, 73%. Global longitudinal strain is preserved, minus 21%. But we have two segments with abnormal longitudinal strain, two segments, septal segments. We measure also a circumferential strain at the mid-level of the ventricle. The average value is 39%, and this is at the upper limit of the normal. Also, we may see that the apical, the anterior septal segment has a very high circumferential strain, minus 44%, which may be a compensation for the reduced longitudinal strain in this segment. Patients with sarcomeric mutations have more severe diastolic dysfunction, and also they show earlier and fast progression to heart failure class 3-4 from their birth. This is different longitudinal strain patterns in different phenotypes of hypertrophic cardiomyopathy. The bullseye plots are different, and the regional, the decreased longitudinal strain, in fact, depends on the segments with the maximal thickness. This study shows that in patients in which genetic test was performed, there is no correlation between longitudinal strain and genotype, but there is a strong correlation with the maximal septal thickness. Global longitudinal strain has a prognostic value. In 14 observational studies, different cutoff values were used, but abnormal longitudinal strain was associated with adverse composite cardiac outcomes and ventricular arrhythmias. And the last case, which I show here, is the case of a 56-year-old woman after septal myectomy and implantation of mitral valve prosthesis. She has congestive heart failure, and what we can see on echo from parasternal long axis view, there is a thickened and elongated cord with a contact with septum in systole. And color Doppler can show us exactly the place where there is subaortic obstruction. The maximal registered gradient was 19.4 milliliter mercury. And we can conclude here that the patients should be examined for all types of abnormalities in the mitral valve apparatus before they send to operation. We decided to send this woman for pacemaker implantation, and she had a subsequent reduction of LV outflow tract gradient. In conclusion, hypertrophic cardiomyopathy includes not only sarcomeric forms, but also phencopies. The prognosis is poor in some patients, but this disease is a treatable disease. The relationships between genotype, phenotype, and lifetime outcomes is very important. Echocardiography has a key role in diagnostic accuracy, risk stratification, and planning therapeutic strategy and monitoring therapy in our patients. Thank you for your attention.
Thank you, Professor Kinova, for the very interesting presentation. There is one question about the related to the patient with the apical hypertrophic cardiomyopathy. Do you would like to use for the routine daily practice cardiac MRI in this population of the patient? And how is possible to differentiate the hypertrophic cardiomyopathy from amyloidosis?
Yes. On the first question, we can use cardiac MR, but not for all patients. We can insist for CMR in patients with some risk for sudden cardiac death. And this is final guideline, American guideline for patient selection for ICD. Also, CMR is very important because we can see the fibrosis, interstitial and replacement fibrosis. And these patients maybe take attention to these patients and follow them. For diagnosis, the differential diagnosis with amyloidosis, yes, we have many patients with amyloidosis recently, but there are some features on which we can rely to make a right diagnosis. And speckle tracking is of one of the speckle tracking with longitudinal strain is one of the parameters which can be used for this differential diagnosis. There is a specific pattern, even though we have different types of, many types of hypertrophic cardiomyopathies, but amyloidosis, obviously, we can see bullseye plot with spared longitudinal strain in the apical regions. And also, this is the opposite pattern of apical hypertrophic cardiomyopathy, in which apical regions have very low values of longitudinal strain.
Okay, thank you, Eli. Dr. Konstantinos, do you have any question? Or you're unmuted at all?
Sorry, I was muted. Professor Kinova, congratulations. Thank you for attending. We have a lot of questions from the audience, but we don't have time. Perhaps just...
I suggest to write to type the answer.
Yes, we can answer. Professor Kinova, if you can answer to Q&A window directly by typing the answer to the audience, it will be great in order to proceed to the next presentations.
Thank you.